She will be giving lecture on equity in women's cancer care, bridging global advances with local realities.
Thank you so much. Oh, you're the best. I'm technically not savvy. Thank you so much for the opportunity to be here, Professor. Hi, the organizing members of BICS, all my friends and colleagues. You're the best. You inspire me. You help me carry on. And so I thank you so much for this topic on equity in women's cancer care. And in thinking about it, much of this has been mentioned today so far, and I'm sure will continue to be mentioned, which is the challenge of how to give good cancer care, the challenge of having good outcomes in cancer care, and what are the various aspects that prevent that? What are the barriers? And the particular question to me was, are there differences between Bangladesh and Boston, where I work in my day job? Is it sort of similar in terms of it? What I would say is that the factors that are the barriers to cancer care are multifactorial. They are different in each society, related to the norms of society, the resources of each particular society. And there are components that have to do with the individual and have to do with the community and society at large. So those are called structural issues around agency, around decision-making on the individual level and on the professional level. So I wanted to kind of walk through that during this small talk. Resources, money, always important. As one of my mentors said, everything is about people, stuff, and money. Everything is about that in terms of what you're looking at. And there's the infrastructure of society. Do you have trains and buses and cars and roads that get people from one place to the other? What are the challenges? You know, you live in Australia and in the outback or in Alaska, and the only way to get there is by a plane. You know, various things like that prevent cancer care. And then finally, and we've talked about this, there's the infrastructure of medicine. Do we have enough radiation oncologists? Do we have enough operating rooms? Do we have a blood bank? And so forth. So lots of interesting questions. And so I want to sort of look at it from the framework of public health. And there are several public health models that I think help us to understand where to focus our analysis and also our resources. So the social ecologic model is one where you look at the various factors from the individual to their family, to their community, to society, to the nation, and how each of those has impact on, we're going to talk about cancer care today. So this social ecologic model is multi-framework. On the individual level, it has to do with education, knowledge, particular reasons for getting help, not getting help, the interpersonal piece of that, family members, being empowered in the family to leave the home, to have money, to have the ability to make medical decisions. There's the community, the norms of society, institutional things. We've talked about healthcare. And finally, at the government level, the Ministry of Health, the policies, laws, you know, how many, you know, we talked about how much of the gross natural product is put into healthcare. So these are the sort of part of our ability to analyze on the individual level. We can ask, what are the attitudes? What's the personal history? What's the behavior? On the relationship issue, we can ask, you know, what are the patterns within families? Where does a particular person, the woman in the family, sit in terms of their communications and their autonomy? Community, institutional levels, you know, what are the neighborhoods like? Are they safe? What are the workplaces like? The schools, what's the educational level? All those sorts of things are factored in this model, okay? So there's other models. There's an interesting model called the theory of planned behavior that it helps us to reflect on our own attitudes as healthcare providers. What is it that leads us to ask the questions that we ask, to respond the way we do to what a patient brings us? So this includes attitude, subjectivity, and leads to behavior. So really, it's so for understanding what our attitudes are, what our judgments are of patients, what is the pressure around us, what are our peers doing that either help us or make it harder for us to do something. For instance, we can be in an environment where there's a lot of mentoring and a lot of open discourse, or we can be in an environment in medicine that's a blame culture, where if you have complications, you're blamed for it. You behave differently in those different settings. There's also something called the health belief model in public health, where you sort of think about why is it people make choices and society makes choices based on beliefs. So on the personal level, it won't happen to me, recognizing risk, thinking about safety, perceived benefits, perceived barriers. This is where the whole issue of stigma of certain diagnoses may come in. Okay, now with that in mind, I thought about it, and I know we can talk big data and GloboCan type statistics and stuff, but I thought I wanted to bring it home to a really good study that came out of the National Institute of Cancer Health, the National Institutes of Cancer Research Hospital, NICRH, Dr. Akhter, Dr. Pervin, other colleagues put together this beautiful study. They included me. I'm very honored, but this is really their study, where they asked the question, what is it that were the barriers to the women they saw with advanced cervical cancer? And what was it that delayed the initiation of therapy? So they did a cross-sectional observational study. They had 138 patients with advanced stage cervical cancer. 2019, 2020 included women from 30 to 70, excluded women with previous hysterectomies or exposure to chemotherapy. And they did face-to-face interviews to ask the question, what were the barriers? And I want you to think about this study in terms of what I said about SEM, sociology, the ecology of model, think about the planned behavior model and so forth, the health belief model. So their questionnaire focused on what they defined as 3 different components of delay to therapy. Delay of care due to patient factors, that was primary delay. Healthcare provider delay, that was the first healthcare provider the patient saw. And then what was called the healthcare system infrastructure delay, finally with diagnosis getting into a cancer center to get your cancer care. And they looked at those 3 components. And they defined in terms of, for a statistical analysis, a primary delay reference category of being less than 60 days or more than 60 days, and a health system delay of less than 30 days or more than 30 days. So health system interval is defined as between the date of the first presentation to a healthcare provider and the date of initiation of treatment. So very interesting. So in terms of who they saw, these 138 women, the majority had stage 2B and 3B disease. A little bit, about 10% had stage 4. So that was their distribution. This basically is their demographics, just to point out that the majority were premenopausal. About 70% were under 56, and only about 8.7% were over 65. I'll just point out that about 30% of these 138 women were illiterate, and about 37% had only a primary education. In terms of the majority were poor, close to 60%. So the majority lived in the rural area, 63.7% versus the urban area. And in terms of asking questions about what was it that potentially prevented them from seeking help? Did they have fear? Were they embarrassed? Was there stigma? And what was their understanding and knowledge of cervical cancer? Had they heard about cervical cancer screening? Had they heard about vaccinations and so forth? This is what they found. They found that really the sort of biggest factor was embarrassment, about 30%. 40% had fear, and astonishingly, close to 85% had not heard about cervical cancer. In terms of symptoms, these patients were symptomatic. They had postcoital bleeding, they had a foul-smelling discharge. In the menopausal setting, 30% had bleeding, and about 12% had pain. Excuse me. So in terms of who did they seek help from? The first contact was the husband in about a little more than a third of the times, other family members or a friend. And in terms of who they first saw, about 37% saw a traditional healer, close to 30% went to a government hospital. And in terms of the numbers of times they needed to go before they got a diagnosis, close to half of them had to go see a provider 3 times or greater before they were diagnosed with their cervical cancer. In terms of these women coming in to be seen in the initial consultation, only 24% got a pelvic exam. The majority, over 75%, did not get a pelvic exam, even though they came in with these symptoms as described. Other interesting factors was where did they live in relation to NICRH? And what you see here is that about 18% lived more than 300 kilometers away. The majority, 43%, lived more than 150 kilometers away. So many of these women lived quite far away. So here's sort of the estimated distances from the primary residence to primary health care. And you see here less than 10 kilometers, greater than 10 kilometers. And you see here home to NICRH, which is the study hospital. So quite big distances, even to the primary healthcare center, greater than 10 kilometers. Okay, so putting that all together. Primary delay, the median was about 75 days. Healthcare provider delay was a month and a half, 44 days. And the healthcare system delay, that is from symptoms to starting and initiating treatment, was 47 days. Okay, so here we have that sort of in a graphic form where you see that 70% had greater than 60-day primary delay, and a health system delay was present in 83%. Okay, so what were the big take-home points from this study, which I think we can universalize? Factors for delay was age. The older women delayed longer. Rural residents, husbands who were day laborers, lower educational opportunities, such as not being able to get an education or have only a primary education. You'll see the odds ratio of delay was 5 in those who were illiterate and 3.6 in those who only had primary education, and definitely fear and embarrassment. In terms of health system interval, really it was the number of pre-referral consultations, which unfortunately were a lot. Odds ratio of 2.5, no pelvic exam at first visit, an odds ratio of 2.2, and distance from the facility. So putting that all together, these factors and delay in treatment increases the proportion of advanced disease, which of course decreases the chance of cure. And that the primary delay of greater than 60 days was 4 times and 12 times greater for patients with stage 3 and stage 4 disease, respectively. So delay and stage were related. And that, interestingly, in this 21st century, 85% of these women had not heard of cervical cancer. And I've summarized here the primary delays due to illiteracy and poverty, the provider delays due to non-performance of speculum exam or having the wrong diagnosis, and then healthcare system delays being lack of availability, access service, and distance. And we know, of course, infrastructure limitations. Putting that all together, how can we fix this? We need to fix it on so many levels. We can't just build more radiation facilities, right? We need to also educate our population. We need to increase their access to schooling, right? We need to make sure they're not illiterate or even just a primary education. We need to think with them and their families, educate them, but also educate their husbands and their family members. So we need school programs. And finally, we also need to educate providers in the community about this and about the importance of the pelvic exam. What I would say is, I'm struck that one of the things that in another study would be interesting to explore would be what was it that prevented the first healthcare providers from doing pelvic exams? Was it a cultural issue? Was it that the patient declined? We don't know that from this particular study. I don't want to point fingers and cause any blame to anyone. I think it's complicated. It's cultural. It's also based on your personal theory of planned behavior, right? So it's a very complicated issue. Many people are working on it, and you all are going to fix it. So I'm very happy to be here and learn from you. Thank you so much.
Thank you, Dr.